Thank you very much, Dr. Aranda. This is great to be here this morning. It's such an essential topic. Caregivers, I think, are the afterthought. Now, I think sometimes what I've learned being in the field is that oftentimes if you're a person of color, you're sort of afterwards. That means when people say, we're fixing the system for everybody, and then we'll take care of you guys. And I think many times those of us who work in the field of caregiving feel the same way. You know, they're fixing the system for the providers, and they're fixing the system for those beneficiaries of insurance programs, and then afterwards they'll worry about the caregivers. So my comments today, let's see, I need to figure out how to advance this. And I haven't figured it out. It's not connected. There we go. Thank you.
Is that the next
yes,
one?
Yes, thank you. So I wanted to give you a sense about the diversity of Asian Americans and Pacific Islanders in the United States. So across the country, there are about 1.4 million Asian Americans and Pacific Islanders who are 65 and older. And California has the lion's share of over 40%. And in most other states where there are more than 50,000 Asian American elders, they only represent about 9% of the population. So I have to say that in the 1970s, when I started doing this work, we were a rare population, and I would say that in many states of the Union, we still are. So this whole issue of diversity, thinking about what differences small populations make in our ability to serve beneficiaries of Medicare, in our ability to meet community needs, is very important. This slide talks about the Asian American and Pacific Islander populations, of which there are over 20. In some communities, the largest ethnic group are Chinese. In others, it's Filipinos. And increasingly in California, in some communities, it's Hmong. But across the country, we can develop some stereotypes of Asian Americans and Pacific Islanders that can be very misleading. In this slide, I used old data from 2000 to demonstrate how if in communities we say, oh, there are only 10% of our elders are Asian Americans and Pacific Islanders, it's really the important thing to think about is the difference among the Asian Americans and Pacific Islanders. In the counties of California, there are many more Asian American elders in Los Angeles than in Sacramento. But proportionally, when we start looking at the local level of planning services, there are many more Vietnamese in Orange County proportionally than in San Francisco. So when we start to target particular ethnic populations and language groups, getting down to the local community level and thinking about whether those those elders who have low incomes, who are Asian Americans and Pacific Islanders, might be more likely be Hmong or Vietnamese or Chinese or Filipino or South Asian or Malaysian or Thai really makes a difference. Many times when we really clump everyone together, it averages out, and it doesn't make sense for local planning and for service providers. So if a hospital that operates in several counties decides that they want to support an Asian American initiative, and they decide they're going to target Chinese, It's very possible that there would be a big difference even among the Chinese, which dialects they speak and how many, what is the likelihood that the elders would be limited English speaking versus third or fourth generation born in the US. So that makes us more complicated. When we look at language, not long ago, about a decade ago, we used to say that 70% of all the Asian elders were limited English proficient. I think because there are so many more now who are born in this country, that proportion is lower, but it's also true that our immigration practices in this country have changed, so that now the likelihood really changes across the different ethnic groups. If you're working with a Hmong family, it's very likely that the elders will not speak any English at all, hardly even a hello, maybe not even smile, because they're not sure why you're there and what you're saying. On the other hand, if you're working with the Japanese American family, the chances really are very high that there will be English speakers in that family. Are they limited English speakers? Do they need additional assistance if you're talking about access or benefits in your insurance plan, or the number of days Medicare is going to pay for when you're in the hospital? I think that many times providers have stereotypes. They hope the family speaks English, but they're not sure. And I think the more, especially in California and across the country, the Asian American community increases in diversity, the more likelihood people are going to say, I don't know, they don't speak English, but I don't know what language they speak, which means it's very difficult to do person-centered care if we're not paying attention to that level of importance in the characteristics of the families. Poverty rates, again, earlier we had a presentation, and it is true on average. Most Asian American elders have about the same experience in poverty as the majority population, but it greatly differs across the ethnic groups. Sometimes it differs because of how recently a population has arrived in the United States, and potentially their inability to work or even have 40 quarters of work, so they might not even have Medicare. I think among the Asian Americans and the Latino elders, there's the highest likelihood of any of the elder ethnic groups to not have Medicare because they have not had an opportunity to work the 40 quarters. And every time in our community when we have a presentation from Social Security, I always remind people to talk about the 40 quarters, and they always turn to me and they say, what? Because I think there is a general assumption that all older persons in the United States have at least Medicare. And in our community, that's not always true. And if you're only needing to rely on Medi-Cal or Medicaid, it can be difficult because many recent refugees and immigrants cannot even get on Medicaid. So it means that working class families are often paying for the care that their elders in their family, their mothers and fathers, their aunts and uncles need. It's somewhat true in many Korean families, and it's somewhat true with many of the Southeast Asian families that came over after welfare reform. So one of the things that ACC Senior Service has done that has really worked is we started talking with caregivers who it took about 4 years for them to say, okay, if that's what you call caregiving, then I'm a caregiver. And if you're offering some help, well, if you're going to pay for the service, we'll talk to you. But if you're just going to talk, we're not too interested. When we started a program to really better identify and help the community grapple with the issue of dementia among the elders, we had so many families, even families that had been in the U.S. for about 3 decades, say, oh, that's just old age. No, you know, there was too much stigma to label mom. Then there were other families who wanted to quickly go to a physician, get labeled, so that mom could have certain kinds of pharmaceuticals because it would help them manage her behavior. So we did a saturation campaign, and I have to say that talking about doing an education campaign is one thing, but it's all about the particular staff person we have. We didn't have a master's prepared person in public health. We actually recruited somebody who had done marketing for a restaurant, and she was fascinated with all the community groups. She contacted civic groups in the Filipino community. She went to talk to church groups. She talked to the Lions chapters. She engaged a whole number of people in addition to providers to talk about dementia in the Asian American community. And we did this for 3 years. She did more than 100 educational sessions every year. And many of those sessions had more than 100 people, and some of the sessions had as few as 4. So we established a campaign where Alzheimer's disease and dementia became household words. And when we began talking with family caregivers, they had heard the word, and they were more interested in hearing what we had to say, going to meetings, understanding that we weren't saying, you're a bad caregiver, you need caregiver training, and instead really organize and engage them as members of the community, helping to get involved in mutual assistance activities, helping each other. We developed a cooperative in an adult day program that we had started at one time, because we found that by informal conversations among the family caregivers, they both learned a lot, they were more accepting of the information, they were able to talk about things that they thought they shouldn't talk about outside of the family, they were able to talk about things that may sound stupid, they were able to share what was happening when mom wasn't sleeping at night or when dad refused to eat. And these are things that in our community oftentimes people need a shared permission and a sense of community to talk about and share and realize that these are common experiences among the caregivers, and also to help them understand what that language is those providers are talking, so that they could ask service providers about services, about support, and not feel that they're either whining all the time, saying things they're not supposed to say, or they're getting somebody to feel sorry for them. Okay. So the time is gone, and I need to close. So there were a lot of other things that we learned. It's in the presentation that you have in your materials. Thank you.